alaikum. I would like to welcome everybody to our annual Thoracic Oncology Forum 2020. We have the pleasure this year to hold it along the annual scientific conference for the Saudi Thoracic Society. As you know, the Saudi Lung Cancer Association is a committee of or association of the Saudi Thoracic Society, with a mission to collaborate and lead national and international initiative to work on lung cancer control, including prevention, education, research, and collaboration on guidelines on evidence-based medicine. We have set objectives that you can see in the website, basically, but the bottom line is trying to make sure that we put all the experts together to work on the mission and the visions of the association. We established the Lung Cancer Academy as the educational arm of the association, and basically many of our educational activities are led by the Lung Cancer Academy. Our educational activities basically targets different healthcare professionals, including primary care, because we know the importance of early detection and prevention of lung cancer. And then we develop different modules targeting subspecialty in thoracic oncology. We are fortunate today to have distinguished faculty who are going to lead the short version of Thoracic Oncology Forum for this year. It's only 2 sessions. And I will not introduce each one of them. I'll just go over the program briefly and some of the announcement. So the first session will be focusing on non-metastatic disease. Will be moderated by Dr. Abdullah Atwergi, who is chairman of the oncology department and consultant at King Fahd Medical City. Then after that will be the talking about the management of metastatic disease, will be chaired by Dr. Hatoun Bakhreba, who is a consultant adult oncology at the Comprehensive Cancer Center in King Fahd Medical City also. As a group, we are proud to produce guidelines on repeated occasions and update them. We have the latest lung cancer guidelines published in 2019. Actually, that was part of the National Cancer Institute initiative. And but this year we have done a tremendous job in publishing management of stage 3 non-small cell lung cancer booklet. As you know, there was a lot of changes in the stage 3. So as a group of authors from the Saudi Lung Cancer Association and the Multidisciplinary Lung Cancer Consortium, with colleagues from the Gulf countries, we were able to produce this nice booklet. And earlier this month, we had the success of publishing the guidelines of stage 3 in the critical review in oncology hematology, which is a very good journal with the impact factor more than 5. In order, please, to get the CME from this activity, please complete the evaluation in the website, and you see it there, the SaudiThoracicsociety.org website. You'll get 16 CME hours. For Gulf Thoracic, as you know, this Gulf Thoracic this year was met with the challenge of the COVID pandemic, but mark your calendar for March 10-13, 2021 for Gulf Thoracic in Dubai. We have made the strategic decision of holding the Thoracic Oncology Forum actually along the side of the mother organization annual meeting in Saudi. So we will not hold it in Dubai as we did in the past for logistically reasons. As you know, we may have cancer sessions in the Gulf Thoracic, but the TUF will be held annually for the next 3 years along the mother organization annual meeting. And for 2021, mark your calendar, it will be November 18 and 20. I would like to thank our sponsors, Lilly Oncology, Bayer Oncology, Sudair Pharma, and MSD Oncology for their generous support to bring to you this activity. And I would like to thank our moderators, speakers, and the in this activity. Without any further delay, I would like to welcome Dr. Abdullah Twergi to lead the first session. Thank you all. Enjoy and learn. Thank you.
Doctor, please turn on your camera and then you can go live now.
It's turned on, by the way.
Okay, you can go live now.
Okay, we can start now.
Yes, Doctor.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you so much, Dr. Jazia. I would like to thank the organizer for being part of such a thoracic family. So hopefully I would like to welcome everyone who have joined us meeting right now, and I wish we can meet in the future face to face and shake hands. And the focus will be mostly on the early and locally advanced non-small cell lung cancer at this session. And we have probably 4 talks to go through. We would like to leave 20 minutes maximum for each talk, and then so please, for the speaker, I would like to stick with the time, 20 minutes, and we'll leave 5 minutes for the questions. For the audience, I would like to invite everyone to use the Q&A part or checkbox, and please send your question as the speaker go through the lectures, and I will try to deliver them to the speaker once we have the lecture. So with this, there will be minor changes in the sequence, but I will keep you updated with that. With no further ado, introduce the first speaker for today's event, Dr. Hamid Al-Husseini. Dr. Hamid Al-Husseini is a medical oncologist at King Faisal Specialty Hospital, and he will walk us through the data that we have with adjuvant therapy in lung cancer. And we have new update from you, Dr. Hamid. I think it's the mic for you. Go ahead.
Okay, Assalamu alaikum. Thank you for inviting me to be a speaker in Thoracic Oncology Forum. So my talk will be about adjuvant therapy in lung cancer. We know worldwide the lung cancer is the leading cause of cancer incidence and mortality, and there was around 2.1 million new lung cancer in 2018, and around 1.8 million deaths also in 2018. When you talk about early stage lung cancer, this means that we are talking about stage 1A up to 3A. And this means that the patient who underwent complete surgical resection. So for early stage non-small cell lung cancer, the surgery is the most effective treatment. However, despite complete surgical resection, there is a high risk of recurrence and death. And it is around 45% for stage 1B, 62% for stage 2, and 76% for stage 3A. And this is mainly because of distant recurrence, which is the most common form of relapse and cause of death. This gives a rationale to use adjuvant therapy. So this is a 5 randomized trial looking for the role of the cisplatin-based chemotherapy versus observation for a patient with a stage 1 to 3A who underwent complete surgical resection. And there was a 3 randomized trial that showed a significant improvement in the 5-year survival. So the IELTS trial, there was around 4.1% improvement in the 5-year survival, which was a significant. GBR10 trial for stage 1B to 2, and they used fenurlobin cisplatin, and the improvement in the survival was 15%, which was a significant. ANITA trial, the improvement in the survival was 8%, which also was significant. While BLT trial showed no benefit by using adjuvant cisplatin-based chemotherapy, and ALBI trial showed a benefit of 3%, but was not significant. So this is lead to the lung adjuvant cisplatin evaluation meta-analysis, which include 5 largest trial using cisplatin-based chemotherapy. Bold analysis of 4,584 patients with a median follow-up of 5.2 years. There was absolute increase in the 5-year survival of 5.4% from the chemotherapy, with the hazard ratio 0.89 with a significant p-value. So by looking to this figure, you can see there was a significant improvement in both overall survival and disease-free survival with the cisplatin-based chemotherapy as compared to control. Overall survival, as I mentioned, 0.89, and disease-free survival was 0.84, which was significant. The most commonly regimen was used is the cisplatin fenurlobin. Stage 2 and 3, there was a significant improvement in the survival with cisplatin-based chemotherapy as compared to the observation. Stage 1B, there was a trend toward the improvement in the overall survival, but was not significant, while stage 1A used of cisplatin-based chemotherapy was associated with a worse survival as compared to observation only. So what about the optimal chemotherapy regimen that can be used? So in this trial, this was phase 3 randomized trial in which 1,501 patients with a stage 1B to 3A completely resected non-small cell lung cancer, treatment naive, randomized either to the cisplatin doublet chemotherapy, and this is investigator choice according to the type of non-small cell lung cancer. If it is squamous, will be like cisplatin with fludarabine, gemcitabine, and docetaxel, while non-squamous, the same chemo, either one of this chemotherapy regimen or pemetrexate. So the arm A will be only cisplatin doublet chemotherapy, while arm B, cisplatin doublet chemotherapy for a 4-cycle plus bevacizumab every 3 weeks and continue as maintenance for 1 year. So in this trial, in overall population, there was no difference in the overall survival between the patient who received chemotherapy alone or chemotherapy plus bevacizumab. There was no significant difference in the overall survival between each chemotherapy regimen in either non-squamous non-small cell lung cancer or squamous small cell lung cancer. When they look for the toxicity, they found that patients using cisplatin with the fludarabine, there was higher incidence of febrile neutropenia as compared to the other cisplatin-based chemotherapy and neutropenia, while with gemcitabine, thrombocytopenia was higher, 23% squamous and 12% in non-squamous, while cisplatin pemetrexate was associated with the lower toxicity regarding grade 3 or 4 as compared to the other cisplatin-based chemotherapy. So what about using carboplatin-based chemotherapy? So in this CLGB trial, 344 patients with a completely resected stage 1B randomized to the paclitaxel carboplatin every 3 weeks for a 4-cycle or observation with a median follow-up of 74 months. In overall population, there was no difference in the overall survival between the patient who received carboplatin-based chemotherapy versus observation, and the same for disease-free survival. When they look for the patient as exploratory analysis, they found that the patient with the larger tumor size, like 4 centimeters or more, there was a significant improvement in the overall survival with the hazard ratio 0.69 with a significant p-value. But there was no difference in the patient with a tumor size less than 4 centimeters. Then I will talk about role of target therapy. So there was like 5 trials looking for the role of the EGFR TKI tyrosine kinase inhibitor in early stage non-small cell lung cancer. So the first 2 randomized trial, including the patient with non-small cell lung cancer and selected for EGFR mutation, while the 3 remaining trials include the patient with the EGFR mutated non-small cell lung cancer. So the BR19 trial, it was a phase 3 randomized trial in which 503 with the stage 1B to 3A completely surgical resected non-small cell lung cancer and selected for EGFR mutation, then modified to allow adjuvant chemotherapy either for 2 years or placebo. In overall population, there was no difference in the disease-free survival or overall survival between the patient who received gefitinib or observation. Among the patients with the EGFR mutation, still there was no difference in the disease-free survival and overall survival, but this is mainly because of the small number of the patient. The total was around 15 patients only. The second trial is the RADIANT trial, 973 patients with the stage 1B to 3A non-small cell lung cancer, completely surgical resected. If they have increased EGFR expression either by FISH or immunohistochemistry, patient randomized 2 to 1 to receive either erlotinib for 2 years or placebo. And in this trial, the same, and selected for EGFR mutation. So in overall population, there was no difference in the disease-free survival or overall survival between the patient who received erlotinib or placebo. But among the patient with the EGFR mutation, the disease-free survival was prolonged with the erlotinib The median was 46 months versus 28.5 months. But there was no difference in the overall survival. This led to the phase 2 trial looking for the role of the erlotinib in a patient with the EGFR mutated non-small cell lung cancer. So in this trial, 100 patients with the early stage non-small cell lung cancer completely resected stage 1A to 3A with the EGFR mutation. Patient completed planned adjuvant chemotherapy plus or minus radiotherapy. Then the patient will receive erlotinib daily for up to 2 years. The primary endpoint was 2-year disease-free survival, and this result will be compared to historic genotype matched control. So in this study, the 2-year disease-free survival was 88%, which is significantly higher than the historical control, which was 76% with a significant p-value. Median time to recurrence after stopping erlotinib was 25 months. So this is lead to the 2 phase 3 randomized trial looking for the role of the EGFR TKI in a patient early stage non-small cell lung cancer with the EGFR mutation. So the first trial, 222 patients with the completely resected stage 2 to 3A non-small cell lung cancer with the EGFR mutation, either exon 19 deletion or exon 21 point mutation. Patient randomized either to the gefitinib, which is the first generation EGFR TKI, for up to 2 years, or cisplatin fenurlapine every 3 weeks for 4 cycles. The primary endpoint was disease-free survival. Secondary endpoint was 3-year disease-free survival, 5-year and overall survival and safety. So in this trial, the median disease-free survival was prolonged with the gefitinib as compared to the chemotherapy, 29 months versus 18 months, with the hazard ratio 0.6 with a significant p-value. And at 3 years, it was 34% with the gefitinib as compared to 27% with the chemotherapy. Then recently, in ASCO 2020, there was update result about this trial with a median follow-up of 80 months. Still, the disease-free survival was significantly prolonged with the gefitinib as compared to the chemotherapy. So the median disease-free survival was 31 months versus 20 months, with the hazard ratio 0.56 with a significant p-value. However, there was no difference in the overall survival between the patient who received gefitinib or chemotherapy. Looking for the adverse event, any grade adverse event, especially like grade 3 or 4, was lower with the gefitinib as compared to the chemotherapy, 12% versus 48%. And you can see hematological toxicity, GI upset was higher with the chemotherapy as compared to the gefitinib. When you look for the skin rash, was more with the gefitinib, and raised liver enzyme, diarrhea, all was more with the gefitinib, but still, I mean, grade 3 or higher was maximum 2%. What about using the 3rd generation EGFR TKI osimertinib? So in this ADAURA study, 682 patients with the completely resected stage 1B to 3A non-small cell lung cancer, non-squamous, with or without adjuvant chemotherapy, for a patient confirmed to have EGFR mutation, either exon 19 deletion or exon 21 point mutation. Patient will be randomized either to receive osimertinib or placebo, and usually 10 weeks without adjuvant chemotherapy, the randomization, or 26 weeks with adjuvant chemotherapy. The primary endpoint was disease-free survival by investigator assessment, and secondary endpoint was the primary was disease-free survival in stage 2 to 3A, while secondary disease-free survival in stage 1B to 3, and overall survival, safety, and health-related quality of life. So the primary endpoint endpoint that showed a significant improvement in the disease-free survival with the osimertinib as compared to the placebo. The median disease-free survival was not reached with the osimertinib versus 20 months with the placebo. At 3 years, it was 80% with osimertinib as compared to 28% only with the placebo, with the hazard ratio 0.17, which was significant. When you look for the disease-free survival for a patient from stage 1B to 3, still there was a significant improvement in the disease-free survival with the osimertinib as compared to the placebo. the median was not reached versus 28 months. At 3 years was 79% versus 41%, with the hazard ratio 0.21 with a significant p-value. The benefit was consistent among all the subgroup analysis, including the patient with a stage 1B with a hazard ratio 0.39, stage 2 hazard ratio 0.17, and the stage 3A was more significant, was more benefit 0.12. Also, the benefits was seen for either patient receive adjuvant chemotherapy or not. So receiving adjuvant chemotherapy hazard ratio 0.16, and without adjuvant chemotherapy, the hazard ratio is 0.23. The other endpoint, it was CNS disease-free survival, and still there was a significant improvement with the osimertinib versus placebo. So the median was not reached versus 48 months with the placebo. The 2-year CNS disease-free survival was 9 versus 85%, with that ratio 0.18, which is 82% reduction in the risk of CNS disease recurrence or death. Overall survival result, but there is a trend in the improvement in the overall survival with the osimertinib as compared to the placebo, 100% at 2 years versus 93%. But we are waiting for the final result of overall survival, and also looking for the pattern of recurrence while patient after receiving osimertinib. When you look for the safety, osimertinib is a well tolerated, and any grade 3 or higher adverse event was around 20% with the osimertinib versus 14% with the placebo. Any adverse event leading to the discontinuation was 11% with the osimertinib. When you look for the adverse event, you can see most of the adverse event was grade 1 and 2, and the grade 3 was maximum 2% or less. The most common adverse event with the osimertinib was mainly diarrhea, paronychia, dry skin, and pruritus. Currently, there is an ongoing trial looking for the role of the target therapy in early stage non-small cell lung cancer, and one of this trial is Alchemist trial. So in this trial, patient with a stage 1B to 3A non-squamous non-small cell lung cancer, after a complete resection and receiving plus or minus adjuvant treatment, with or without radiation, patient looking for the tissue. So if patient has ALK positive, then the patient will go to the phase 3 trial of crizotinib versus placebo for 2 years, while patient with the EGFR mutant will be randomized to the either erlotinib versus placebo for 2 years. The other trial is ALINA trial, and this trial is a patient with a resected stage 1B to 3A ALK positive non-small cell lung cancer will be randomized either to the alectinib for 2 years or platinum-based chemotherapy for a 4 cycle and then follow-up. And the primary endpoint disease-free survival per investigator. So we are sharing, we are participating in this trial, and we are welcoming any patient who has early stage lung cancer with ALK positive to refer the patient to our hospital, so this patient can be participating in this trial. So in conclusion, for a patient with a stage 2 and 3 non-small cell lung cancer, should be treated with a 4 cycle of cisplatin-based chemotherapy. The role of carboplatin-based combination as adjuvant therapy remain uncertain, but you may use it for a patient with a significant comorbidities or if the patient cannot tolerate cisplatin-based chemotherapy. Adjuvant chemotherapy can be considered for a patient with a stage 1B non-small cell lung cancer and the high-risk features like lesion 4 centimeter or more, poorly differentiated, with resection, vascular invasion. There is no role for adjuvant chemotherapy in a patient with a stage 1A non-small cell lung cancer. Recently, adjuvant osimertinib can be considered for a completely resected stage 1B to 3A EGFR mutated non-small cell lung cancer. Thank you.
Thank you so much, Dr. Hamid, for this an overview on the data that we have for the early stage. I think we have, because you stick with the time, so I think we will have few questions. The first question, I would like to ask the first question, and there is, the IDORA trial, they have included patients who have been given chemotherapy or no chemotherapy. The question is, do those patients need chemotherapy, adjuvant chemotherapy, despite the benefit that we have seen with EGFR TKI? And I'm not sure if that's trial have answered the question, but what's the role of chemotherapy? Do those patients need chemotherapy?
Stage 2 and 3, I think they need the chemotherapy, and we saw the trials that showed significant improvement with the adjuvant chemotherapy. And after that, I think the patient can continue on zimertinib. Maybe for stage 1B, you may consider only EGFR TKI, but we don't have trial that should clearly, like randomized trial comparing EGFR TKI versus chemotherapy, to make it clear that the EGFR TKI can be used instead of chemotherapy. So I think until now, if patient need adjuvant chemotherapy, should receive adjuvant chemotherapy first, and then after that, if small cell lung cancer, to be treated with the EGFR TKI or zimertinib for 3 years. I cannot hear you.
And that is probably leading to the second question that I'm going to go with is, do you know, you have shown the data that we have with an Asian trial, the one with gefitinib versus chemotherapy, and as we move on, the survival outcome was, or the benefit was disappeared. And in fact, there is no survival benefit. And the concern is, could this trial also have the same way where probably we might not get survival advantage, given the fact that we're giving adjuvant therapies not to control the disease, it's just to cure more patients? Would you think it's practice changing, or do we have to wait for an overall survival to prove that? What's your thought on that?
I think it is practice change. It showed significant improvement in the disease-free survival with the hazard ratio like 0.18, 0.2, and also it showed significant improvement in the disease-free survival in the CNS with the with the hazard ratio the same, like 0.18, and it is well tolerated. So and we know, most of the patients with either stage 1B to 3A, the risk of the relapse is very high. So with this, very significant disease-free survival, and also the CNS better control with the lower toxicity, I think this will change our practice. Still we are looking in the future to look for the overall survival and pattern of the recurrence. But with this significant improvement, osimertinib better to be considered as adjuvant therapy now after chemotherapy.
Thank you so much, Hamid. I think it's time to move to our next speaker for clinical molecular genetics and genomics at National Guard Hospital in King Abdulaziz Medical City. Dr. Saeed, he will walk us through an important topic, which is the advance in the disease profiling in lung cancer. And it's things that has been changed over the last few years, and probably we had more things from molecular in order to change the way we treat our patients. So Dr. Saeed, are you with us, or can you share your slide?
Thank you very much, Dr. Abdullah, Dr. Jazia, and for the inviting committee. It's my pleasure to speak today about the advances in disease profiling. It's a huge topic. There is a lot of exciting news, and I will try to summarize some of the exciting findings. So, as we move forward from the histopathology-based subtyping of two types, squamous and adenocarcinoma, into the molecular with 10 or 15 different subtyping, we always think about the fact that these biomarkers that help fueling the targeted and the immunotherapy are coming from different processes and levels. At the DNA level, as you all know, the EGFR, BRAF, and KRAS. And at the RNA level, we see we can pick up the ALK and the ROS1. And at the protein level, we pick the BDL1 and NTRK fusion as a screening process. And this is what we see based on these biomarkers, an exciting list of growing targeted and immunotherapies that we see every couple of months. We see an addition of regimens. And that's very exciting. And the way we did it in the last few years, that was a very great story that I think all of our hospitals and teams went through. From single gene testing, moving forward with a small NGS panel, next generation sequencing, toward medium and large panel. And along this process, we witness an increase in the diagnostic yield and improvement in the turnaround time. For example, 2016, we used to, at least in our hospital at National Guard in Riyadh, we used to do single gene testing EGFR, and the outcome is positive in 25% of non-small lung cancer. ALK added 7%, and ROS1, when we do the FISH, added 1%. And this together yielded 33% in our patients. The number of reports, however, was 3 to 4 reports based on the technologies that we used. And turnaround time can extend up to 4 weeks because not all tests available in all hospitals. So we used to send some of these biomarkers outside, especially the FISH. And it cost up to 4,000 riyal for these 3 single tests. 1,000 riyal, 500 if it's done locally in-house. And if it's done at commercial, it's usually double or triple the cost. So when we introduced this small NGS panel, and by small I mean 10 genes or 11 genes, that's mostly the part of the guidelines. 10 of those were at the DNA level, and 4 at the RNA level. ALK and ROS1, as already known as, has to be done. RIT and MIT used to be emerging, and the evidence to support that is increasing more and more in the lung cancer. So when we introduced this, and in 1 year, we sequenced 220 patients between 2018 and 19, and we added another 4% for the RIT, 4% for MIT, which is slightly higher than the global percentages, which is around 2 and 3%. But probably because our cohort is small, we will observe this percentage to decrease over time. KRAS was not part of the single gene testing, and now we see at least 11% of our patients having one of the KRAS mutations. So the yield, diagnostic yield with introducing the smallest NGS panel that we could find added at least 20%, which is fantastic news. Not only that, the cost did not increase a lot. So we are actually saving 1,000 riyal compared to send out. And the turnaround time decreased dramatically from 4 or 5 weeks to only 10 days. However, I think our appetite, whether it's pathology or oncology, is increasing to add more and more biomarkers. So we introduced the medium NGS panel, 50 genes. And we are talking also to add the 500 gene panel in our arsenal. And these 500 genes not only include the most commonly mutated genes in cancer, but also can pick up the microsatellite instability as well as the tumor mutation burden for the immunotherapy. So we envision, and we already started seeing enteric fusions picked up by this medium to large NGS panel, MSI as well, and as well as TMP. And we are seeing at least 5 to 10% increase in our diagnostic yield, which means using only a single NGS panel, the medium or large, can pick up to 60% of our patients with an actionable mutation, which is really great news. The costs, however, increased a little bit to $6,000. It may seem a little bit steep, but compared to the international prices, this is almost 70% less and twice as fast as sending outside. And I think the cost, given that it's one-stop shop for the patient, is very reasonable when taking into account that it's 500 genes and more. For those 40% that we don't see any results or actionable, there is a program for the research where we actually utilize whole exome sequencing and whole transcriptome to start figuring out what are the new novel biomarkers that we will see repeated in our patients. So all this is good, and I think I wanted to move a little bit beyond these simple biomarkers to three small subjects: the multi-omics, the liquid biopsy, and I'm not talking about cell-free DNA, but others markers, and the integration of artificial intelligence, which used to be very futuristic and sci-fi, but now we are, publications are coming out, and it's amazing the power that this brings to our clinical practices. And they will put some few examples. So let's start with the multi-omics approach. And beyond the DNA, RNA, and protein levels, there is many things that we can pick up. In the lower part, the genomic part, it could be somatic, which is what we do, but it's also inherited germline mutation that increase the risk for developing cancer. And we start seeing in the last few years very good publications supporting this, and they will show an example. However, epigenetics, as you know, the hypermethylation, and microRNA also is a huge area of research. Proteomics, and I don't speak about single proteins, but actually screening a lot of proteins at the same time, similar to what we do at the genome. And not only studying the protein itself, but the post-translational modification, the phosphorylation, the glycylation, the ubiquitination, all these are increasing our biomarkers arsenal. And some of these are not reaching yet the clinical phase, but these are moving from the basic research to the translational phase. And I think with more validation and verification, some of these will find its way to our clinical practice in the upcoming couple of years. So I will just, in this part, I will focus on only in the inherited mutation and how they increase the risk for cancer. A fantastic paper was published in last May, a couple of months ago, where the authors screened more than 30,000 patients and healthy controls and picked up two very strong signals of germline mutation. One at the ATM gene, which is known for ataxia-telangiectasia. And this mutation here is a missense at this position. And the odd ratio was 8.8 with a very significant p-value. You can see the purple color here is this mutation and how strong is the p-value compared to the background. The other signal they picked up was in a novel gene called KIAA0930. And also it has an odd ratio of 2.6 with a very significant p-value. And the authors found that this odd ratio, when they corrected for gender and the type of the cancer and the age, was very significant compared to controls, especially in females. Females had a higher odd ratio than the males. The lung adenocarcinoma was more than the squamous and the small cell. And when they broke it down, which is the left figure, between female and female non-smoker, it doesn't matter. As long as the subject is a female, it's increased their odd ratio significantly compared to others. This was, the top figures was the discovery cohort. They verify and replicate this, and the same signal appeared again very strong in the females and in the lung adenocarcinoma, but not so much in the squamous cell. And what's interesting is that the homozygous mutation in the ATM, when it's not heterozygous, that means they are carrying 2 copies, all patients who carry that develop lung cancer. Doesn't matter if they are smoker or not. It doesn't matter if they are female or not. If they are homozygous, 100% of them develop lung cancer. So this could be a fantastic genetic testing to predict and screen for the patients. And the same findings was more in the Ashkenazi Jewish in lung cancer. And the same signal also appeared very strong in females as well. And they found that 4% of the Ashkenazi Jewish carry this mutation. So this could help developing screening program for the lung cancer, at least in those who carry this mutation. And we envision more and more of these germline mutation to appear, not only in lung cancer, but generally speaking. So we will see that blood testing for germline mutation going to be part of the screening in high-risk families. Moving to the liquid biopsy, and we have been doing this in the last few years as a complementary to the tissue diagnosis. And it's been great. If obtaining a tissue is not possible, liquid biopsy come to the rescue, and we can pick up most common mutation, EGFR, KRAS, BRAF, etc., from the blood with a very reliable testing results. However, we are looking into circulating tumor cells. And they are accompanied not only with the complete cells with the nucleus and the whole genome inside it, but they come also with many different physicals, tumor-derived exosomes, microphysicals, apoptotic physicals, and each one of those carry microRNAs and different biomarkers that's showing strong predictive value in some of the lung cancers. But it's not yet, again, not reaching the clinical practice, but the pace of the discoveries in this area is mind-boggling. And we are trying to, in our lab, to start using some of these technologies, preparing to the next couple of years. And the way we isolate cells, there's many methods. Most important one, because they have a different size than the white blood cells and other cells. We use a narrow, we make the cells flow through different small channels, and they trap it based on the size. Another method is these cells, when they flow in a circular channel, they tend to attach to one side, not the other. So this is another way of doing this, and this is the clear cell technology. Another way is to put these cells inside a very small vortex, and they circulate, and then we attract them or capture them at the sides. And once we have this, we can do so many different things with these cells. The first one is the single cell analysis. So no longer we go with a huge heterogeneous group of cancer cells, but actually we are taking one cell at a time, open the nucleus, take all the DNA and RNA, and start doing exactly what we do as if we are dealing with a tissue biopsy. The other thing is we can immediately apply FISH and the BCR methods very simply on these cells. And we can take these cells and grow it outside to mimic the tissue and test many the pharmacogenetics and response to different FDA-approved treatments. And then a very recent review about these technologies, I will just highlight one of them by the Tan et al., his group, where they studied the FISH for the ALK on the circulating tumor cells using clear cell technology. And they found that the concordance is more than 90%, which is a great news. Because in our experience with the cell-free DNA, it's not great to pick up the fusions. So having this complete cell with its nucleus will help us to capture the RNA. Circulating RNA is usually degraded very quickly, especially with the long transportation. So we are looking into this technology to enhance our ability to pick up all the RNA fusions. Moving to the last part, which is the artificial intelligence integration in our daily practices. And there is two major areas for the artificial intelligence. One in the radiology. We start extracting the features, whether it's the volume, the contracts, the size, etc. So they have to do this all manually. And then they apply machine learning methods, many statistical methods, super vector machine, etc. And what they are trying to do here is they correlate between those features they are picking up from the images with the biomarkers. Can we predict EGFR status from these features or not? Can we, for example, the survival also can be done through this method. The new method, however, the deep learning, which is amazing, and it's black box. We don't do none of this work at all. All this is done manually. We just feed in the algorithm these images, the more the better, and it will do the delineation by itself. It will keep learning by itself. It will extract the most important features, and then it's can answer questions for a prognosis and predictive values. And this is has been there have been many works around this area. For example, Yoon and his group tried to see how can they predict Al-Cross 100 fusions from PET scan and CT scan, and they reached up to 72% and specificity, which is not too bad actually, given that it's a classical approach. Deep learning, however, is actually improving this by at least 10%, and more and more evidence supporting this. The problem with the deep learning is it just tells us what's happening, but it doesn't tell us why. What is the exact feature? Because it's do this magic internally without any human intervention. The same thing with the digital pathology. To the computer, it really doesn't matter if it is radiology or it's pathology. It's by the end of the day, it's just an image. It's pixelated. It will do the same classical or deep learning approach, and it will do the linking and the predictive with the biomarkers as well. And this figure shows many publications done for using digital pathology automatically to subtype different cancers.
We have two more minutes, Dr. Said.
Yes, I'm almost done. The subtyping for different cancers, the light yellow is internal validation, the darker is external, and the very dark orange is the FDA approved. This was done for grading, and you can see there is only one paper in the prostate cancer in the middle circle, which was got FDA approved, and that was a few months ago. It's a company in the US where they got FDA clearance for their digital pathology view for the prostate cancer. And this is telling us what are we going to see in the next couple of years, more digital pathology and artificial intelligence integration. So with that, I'm reaching to the end of my talk. The multi-omics, we already started linking DNA and RNA. Now we are adding the germline and more very soon the proteomics. The liquid biopsy, cell-free DNA is not the only thing that we can pick up now. Circulating tumor cell is coming very soon. And artificial intelligence is going to compete with us as physician, at least in the radiology and the digital pathology. I hope it will not touch the oncology part. And with that, I would like to thank you very much.
Thank you so much, Dr. Said, for this nice overview. I think I have only one question for this lecture. It's probably a practical question rather than anything else. You are facing now your lab is receiving samples from different places for tissue, for liquid, and you know the challenges that we are facing as a clinician: limited tissue. Many biomarkers need from those limited tissue. I was wondering what's kind of challenge you face with the samples that you received from different places, any rejection rates, what are the reasons, something like that, if you have an idea about that.
Yeah, absolutely. So for the tissue part, I think we are reaching 15% rejection rates. For the most important reason is the small size. And I understand why they keep sending it, because they have to try anyway. And we accept that. Sometimes we go through the NGS twice, and then we release a field. The other thing is actually not sticking with the formalin percentages. I think some labs, especially the remote hospitals, they use more than 10%, or they keep the tissue in the formalin for more than 48 hours. So when the sample comes to us, the DNA and RNA is very fragmented and we cannot do it. So I would say these two are the major factors. For the liquid biopsy, it used to be very high failure rate, especially in the summer because of the heat. But recently, I think the most important one is the hemolysis. And this is usually when the samples come from Najran or Arar. It takes a couple of days for shipping. But 15% failure rejection for tissue, probably 5 to 10 for the liquid biopsy.
Thank you so much, Dr. Said, and thank you for having you for today's event. I think it's time to move to our next speaker for today's event. I would like to welcome Dr. Nafisa. Dr. Nafisa is a medical oncologist at King Abdulaziz Medical City in National Guard, Riyadh. She will walk us through the data, especially the recent data that we have with the stage 3 non-small cell lung cancer and immunotherapy, and I'm sure we have also an update with this regard. Dr. Nafisa, I think the mic is yours.
Please.
Thank you. So what about these two slides? Can you see them?
Go ahead.
Go ahead, Dr. Nafisa, go ahead.
Okay. Assalamu alaikum. Good evening, everyone. Thank you, Prof. Rainy and Prof. Jazia and the organizing committee for inviting me. I will go ahead and start the presentation. My talk today is about role of immunotherapy in stage 3 non-small cell lung cancer. We know that lung cancer is killing disease. It kills around 2 million patients annually, and this is definitely because the lack of there's a lack in the improvement in overall survival if we compare it with the other cancer, and this is lack in the improvement in survival because of many reasons. One of them is the stigma of the disease and the late onset of the symptoms and late stage at the time of presentation. So what about the stage 3 non-small cell lung cancer? It's a heterogeneous group of diseases ranging from stage 3A, stage 3B, and stage 3C. And Excuse me, I'm seeing, sorry for that, I'm seeing another screen in my...
The screen, Doctora, with the survival rate.
Yeah, I'm seeing this screen, but on top of that, I'm seeing unable to start video, and there is another screen, connection is lost, so I don't know.
You are alive, I can see you, and your voice is clear, so you can able to proceed with the slide, or you can't?
I can do that, but those two slides are covering my presentation. For me, I can't.
If there's an X, take it out. If there's something. Make it full screen, Doctora Nafisa, if you can. Yes, full screen. Yes, Dr. Nafisa. Can you keep going, or you have any technical issues? Dr. Nafisa, you are muted. I think Dr. Nafisa have technical issues. Please, could you help her with that, please?
Okay. Yes, Dr.
You have a problem with the slide, or what?
No, I don't have a problem with the slide. In the top of my slide, there is another slide appearing like saying you cannot connect. There are two slides on top of it. So now I'm okay.
Okay, go ahead. Carry on.
So, a patient with stage 3 non-small cell lung cancer, as I said, they're a heterogeneous group of patients with different tumor size and different lymph node involvement. And you cannot decide about the treatment of those patients without taking the cases to tumor board. And with the tumor board, we need everybody to be there. We need the oncologist, radiation oncologist, pathologist, and our radiology team, of course. So how do we treat our patient with stage 3 currently? What do you have in the current practice? So the standard of care till now is a concurrent chemoradiation or sequential chemorad. Although the concurrent is better than sequential, and overall, of course, it gave overall survival benefit, but still we are seeing patients who cannot stand the concurrent chemorad, and because we know the toxicity is very high. So sequential sometimes is needed for some patients. What about induction chemotherapy? Sometimes we see patients who are having big tumor, and when you bring the patient to the tumor board, the radiation oncologist will tell you this tumor bed is very big, and the radiation will give more toxicity. So they will ask you to downstage or minimize the tumor for them before starting concurrent chemoradiation. So this is one of the practices that we are doing for stage 3, like induction chemotherapy, giving 2 or 3 cycles. And consolidation is when you finish your concurrent chemoradiation, you give patient like 2 cycles after that. These are our practices, but we don't know if giving induction or giving consolidation have any benefit for the patient, because all the data about that was not positive. So what is new in the treatment of stage 3 non-small cell lung cancer? So immunotherapy has been introduced. We know that in stage 4, and it gave good PFS and good overall survival. So the next logic and wise decision was to try the immunotherapy in early stage lung cancer. So immunotherapy is like immune checkpoint inhibitor, and this immune checkpoint inhibitor, we know the role of them in the cancer cells. So we have the PD-1 and PD-L1. The PD-1 is located at the T cells, and the PD-L1 is located at the tumor cells. So binding 1 and PD-L1 will prevent T cell from recognition of tumor cells, so to not be able to attack them. So the idea of immunotherapy is by either by anti-PD-1 or anti-PD-L1, those medication will break this bond and make the T cells able to recognize cancer cells. So this is in a simple way the idea of immunotherapy in the cancer. So we know from previous trial and from stage 4 disease, combination of immunotherapy give a great result, because chemotherapy we know cause immunogenic cell death. So this will lead to cell modulation and facilitate the job of immunotherapy. Not only that, recently we found that radiation therapy can also do this by interacting with DNA, causing another, so also cause immunogenic cell death and modulation of tumor microenvironment. So by combining chemotherapy, immunotherapy, and radiation therapy, will increase the toxicity, will increase tumor necrosis, and will increase cell death, of course. So this is the idea of combination of the 3 modality of treatment in stage 3 small lung cancer led to so the best T cells and prevent the combination of PD-1 to PD-L1, and of course recognition of the tumor cells by the T cells. So the rationale of the Pacific trial, they found that in the murine cells, that when the cells receive radiation therapy, this will increase the production of PD-L1. So if you notice here, the yellow one, those are the cells did not receive radiation, are the cells that receive radiation. So we can see obviously after radiation therapy, the number of PD-L1 levels increase, and they found also there is synergy between anti-PD-L1 and radiation. So the red one or the pink one, these are the cells that survive after radiation. So cells with high PD-L1 and then receive radiation. So it survives better than cells that having high PD-L1 and receive radiation but does not receive anti-PD-L1. So there is synergism between radiation and production of PD-L1, and there is synergism between PD-L1, radiation, and immune checkpoint inhibitor. So what is a Pacific trial? What was this? What was the trial design? They took patients who are having local advanced disease, unresectable disease, non-small cell lung cancer. After completion of concurrent chemoradiation, not only completion and no disease progression after that. And they were randomized to 2 arms. The first arm received durvalumab, and the other arm was only observed or received placebo. So durvalumab was given maximum 42 days after completion of treatment. It was given like 10 milligram per kg every 2 weeks, and it continued for 1 year. Primary endpoint was PFS and overall survival, and secondary endpoint were overall response rate and patient-reported outcome. So looking at the PFS in this trial, we can see that the early separation of the 2 curves gave us very excellent PFS at 12 months. PFS was 55% in the durvalumab arm, and it was 34% in the placebo arm. So follow-up of this result, the PFS also improved after when you look at the curve at 2 years, and at 3 years there was significant improvement. At 3 years there was 39, about 40% of the patient did not have disease progression, and 20% in the placebo arm. After 4 years, 35% of the patient they did not have disease progression, while 20% had disease progression in the placebo arm. So what about the overall survival? There was overall survival benefit in the durvalumab arm. So patient at 24 months, they have around at 1 year, they were around 83% overall survival benefit, while it was only 75%. This is what at 2 years. So a significant improvement in PFS, a significant improvement at overall survival. So here we have the updated result of the Pacific trial. We can see at 3 years follow-up, 57% of the patients were alive, while only 44% were alive the placebo arm. And this is a very significant result for patients who are having stage 3. This is actually the first time to see a medication that causes overall survival benefit. So exploratory analysis looking at patients who had who received treatment after disease progression, and this was very significant as well, because only 41 patients had disease progression and went for second line treatment, and 54 patients had disease progression and went to second line in the placebo arm. And those second line are distributed between platinum doublet or single treatment chemotherapy or immunotherapy or targeted therapy. So this is updated still after 4 years follow-up of Pacific trial. Overall survival, as I mentioned, was 50% in the durvalumab arm, and it was 36% in the placebo arm, and the hazard ratio was 0.71. So what about subgroup analysis? They look at that, looking at the sex, disease stage, histology, and smoking history, PD-L1 expression, and EGFR mutation. The good thing that all subgroup and all the patients benefited from adding durvalumab, irrespective of the, as I mentioned, histology or smoking history or PD-L1 or EGFR mutation. So we can see very clearly that all the patients had good response to durvalumab. So when they look specifically at EGFR mutation, they found there was only around 29 patients were having positive EGFR mutation. Few patients, 300 patients were having wild type, and 130 patients where their EGFR mutation was unknown. Still, looking at that, we can see that those patients benefited from durvalumab, but regarding the overall survival, it's early to talk about that because the number of patients was small. So we cannot talk about overall survival while we are having 29 patients out of 700 patients. So I think more trials are needed to look at this. But in general, we can say patient up to this point, we can say that patients who were having EGFR mutation still benefit from durvalumab. What about PD-L1 expression? So they look at the patients who are having PD-L1 overexpression. The cutoff was 25%. So we can see that very clear in overall survival that there was benefit from patients who are having either above or below 25%. Again, they benefit from the treatment, and the PFS was also better in the patients who were having, were good in patients who are having below or above 25%. Unplanned post hoc analysis, actually, they look at the patients who are having PD-L1 less than 1%. And we can see very clear here that the only patient who did not benefit from durvalumab. So patients above 1%, yes, they do benefit, but below that, this is very unsure from the effect of durvalumab on them. So what about safety profile? There was a lot of in the arm of durvalumab. There was a lot of cough, pneumonitis, treatment-induced pneumonitis, GI toxicity, and skin toxicity. If we look at any grade, yes, we can see a big difference. There was a high number of events in the durvalumab. If we look specifically at grade 3 and 4, we can see that the difference is not big between patients who received placebo and patients who are receiving was manageable, and the rate of discontinuation of treatment was very small, actually. Again, looking at skin toxicity and thyroid and pneumonitis, we can see the grade 3 and grade 4, they are comparable. Maybe the fatigue was a little, hypothyroidism definitely was higher in the durvalumab arm, the skin toxicity was higher, but still you can compare, it's comparable between the placebo and durvalumab arm.
We have two more minutes, Dr. Nafisa.
Okay, the secondary endpoint, also they look at the adverse event like pneumonitis. Again, the medication was safe and the toxicity was manageable. So the rate of discontinuation, it was not high. It was only like 5%, 15%, while it was 6% in the placebo arm. So durvalumab after concurrent chemoradiation give overall survival benefit and PFS benefit. So what about patients who did not fit the criteria of Pacific trial? In the Pacific 2, they consider those patients, actually patients who might have disease progression immediately or within the treatment, like during the concurrent chemoradiation. So considering those patients, they added durvalumab as early as possible along with immune chemotherapy and radiation. So they gave durvalumab with chemotherapy, and then they maintained patient on durvalumab. The other arm was concurrent chemoradiation plus placebo, and then maintenance placebo. So still we're waiting for the result of this trial. Pacific 6, they consider another group of patients who did not fit the criteria of Pacific. In the Pacific, we know that they took patients who are having performance 0 to 1. So here, patients who are not having good performance status, who cannot tolerate concurrent chemoradiation, they were patients who are having comorbidities, a lot of comorbidities, they had been considered in this trial. So what happened here, they gave chemotherapy and then radiation therapy followed by maintenance durvalumab. So we are waiting for the result of this. What about neoadjuvant trial? We have many of them. We have CheckMate, where nivolumab is introduced in the neoadjuvant setting, followed by surgery, and then maintenance nivolumab. We have Keynote 671, where pembrolizumab was given along with chemotherapy, then surgery, and then maintenance pembrolizumab. So the striking or the very exciting result came from Nadim trial when they gave immunotherapy nivolumab along with chemotherapy. They gave platinum plus chemo plus nivolumab, and then patient underwent surgery, and then adjuvant maintained patient on nivolumab. So when they look at radiological response, there was complete response. This trial is ongoing, but they took the first 41 patients and look at them radiologically and pathologically. There was complete pathological response in 3 patients, partial response in 33, and stable disease in 8 patients. Pathological response, there was complete pathological response in 25 patients and major pathological response in 35 patients. So in the adjuvant setting, we have another trial. We have Empower 10, where atezolizumab was given post-surgery, and we have trials that showing nivolumab, given after surgery. So one of the trials that had been ongoing but showing good result is Empower 10, where they introduced atezolizumab post-surgery. In this trial, cisplatin was allowed to be given either with pemetrexate, nivolumab, or docetaxel. Then patient underwent surgery, and then maintenance arm, as adjuvant treatment with atezolizumab was given for 1 year, and the other arm was only observed. So the primary endpoint was disease-free survival, and secondary point was overall survival. Lung cancer, some of them are in the pipeline, some of them are ongoing.
The subgroup analysis, and this is something we do see with many other clinical trials. We do see the extreme, the small numbers. You have mentioned some of those negative PD-L1, EGFR, those who has been treated within 2 weeks, how these differences in the small or the subgroup analysis can impact on our choices of treatment. What's your quote on that?
Yeah, we have like resistant immunotherapy. We have two resistant immunotherapy and secondary resistant or acquired resistant. So one of the main reasons of primary resistance is presence of mutation. So I would be very skeptical using immunotherapy in patient who is harboring the target mutation like EGFR or ALK or ROS1. So I think will not use this medication. If we have another alternative, maybe chemotherapy will be better as a second line, or if we're talking about metastatic setting. But definitely, it's not the best selection to give immunotherapy for patients who are having mutation. Although here, as I mentioned, there was good response. Still, the patients were responding. They maintained overall survival, but the number of patients very clear was very small. So it's early to tell, but they still benefited. But more trials, we need more results from more trials and large number of patients.
Thank you so much, Dr. Nafisa. Thanks for having you for the event.
Thank you.
So I think now we're moving to our next speaker for our session. I would like to welcome Dr. Salim Al-Shehri. Dr. Salim is a radiation oncologist from King Abdulaziz Medical City, National Guard, Riyadh. He will walk us through the radiation part when we deal with an early stage lung cancer. And so we're moving from radiation, and with this I would like to welcome Dr. Salim, and nice for having you for today's event. I think your slide, can you share your slide please, Dr. Salim? Okay, good. You can go. Thanks.
Hello, everyone. I would like to thank Prof. Jazia and the organizing committee for giving me this chance for this talk to talk about the update on radiotherapy in early stage non-small cell lung cancer. Actually, this is an interesting controversy topic between the surgical field and the radiation oncology on early stage non-small cell lung cancer. First of all, we would just give an idea and a glance about radiation therapy on the delivery way of it in early stage lung cancer. All available evidence which showed the survival advantages based on phase 3 trials has been delivered in the way of conventional radiotherapy, as you see in the right side of the slide. Conventional radiations mean when you deliver the radiation in a conventional way with a small dose per day, and the beam usually go through and pass through the normal tissue structures, as you see here in the picture, like the heart and the esophagus and the spinal cord. Nowadays, radiation therapy has been evolved, radically changed in the way how to deliver a huge dose in accurate and precise manner, targeted to the tumor only, and preserve the organ at risks. The middle of the slide, you see how is even the proton therapy, which is the recent advance of delivering radiation, and how is the conformal and the shape of the radiation targeting the primary tumor. These two videos shows how this surgery has delivered to the moving target of the lung tumor. So when we talk about radiation in early stage lung cancer, we talk about this technique, stereotactic ablative radiotherapy, not the conventional type of radiation. The role of stereotactic radiosurgery initially has been established back in 2006 and then updated in 2013 by Dr. Timmerman from Indiana University. Initially, they recruited T1, T2A, N0 in the RTOG 0618 for the tumors of less than 5 centimeter, away from the central structure, the proximal bronchial tree. We define it as peripheral tumors. They provide a huge dose of 60 gray in 3 fractions, and they proved a promising result with 2 years local control of 80% and overall survival of 80% with a toxicity of 7%. That pushed for 2 trials, STARS and ROSEL trial. Both of them, unfortunately, was terminated because of the poor accrual of patients. So this interesting trial, published in 2015, they pooled these 2 randomized trials, and they found that an early stage tumor of T1, T2 less than 4 centimeter, when you give a stereotactic ablative radio therapy, you achieve the 3-year survival of 95% with acceptable toxicity of less than 10% when you compare it with surgery. This is an interesting meta-analysis where they reviewed all stage 1 non-small cell lung cancer treated either with sublobar resection, lobectomy, and compared it with the outcome of stereotactic ablative body radiotherapy. And they found that when we talk about overall survival, still it's favoring towards surgery, either lobectomy or sublobar resection, with around 10% superior. But when we talk about local regional recurrence, there was no significant differences between the 2 local therapy. So we conclude that when you have a stage 1 disease, non-small cell lung cancer, surgery is still superior in the term of overall survival. This is another meta-analysis. It's interesting to see when they pool all these patients who had stage 1 non-small cell lung cancer, and either they proceeded with surgery or stereotactic ablative body radiotherapy. The kind of surgery is of a significant matter, as well as the category of the patients. When you have a standard risk patients, all of these patients, they will do better and they will have superior outcome when they proceed with surgery, not stereotactic ablative body radiotherapy. But when you go to the high risk patients or medically inoperable patients, then the outcome will start to be comparable between both modalities, as you see here in this in the table. Controversy is still ongoing between either to proceed with surgery or stereotactic ablative body radiotherapy. We will emphasize on the point again that when we talk about overall survival, the optimal treatment still to proceed with surgery. But what kind of surgery? Lobectomy. Then the overall survival is dominant towards surgery with a significant P value. But when we talk about cost-specific survival or local recurrence, then the outcome will be comparable. So this is what we are trying to propose is this the precise of being accurate? When you provide the radiation therapy, you will just treat the tumor itself with a margin of tolerance of 5 millimeter maximum. So as most of you and we know, at the definition of regional recurrence is it when the tumor recurs in the same loop? Then, of course, when the patient had lobectomy, then the regional recurrence will be superior in terms of control towards surgery. Then that makes the stereotactic ablative radiotherapy move toward comparable results in high-risk patients and in inoperable patients and in the elderly as well. So this is a national survey done on the patients of, they defined elderly patients who had an age of more than 80 years old, and they found the providing and the time of adopting stereotactic ablative body radiotherapy is becoming significant, and the earlier dedication of adopting stereotactic radiosurgery will improve survival in these kind of patients. So this is a trial showed what if you have an inoperable early stage non-small cell lung cancer and you provided a stereotactic body radiotherapy, or you had no. The outcome was promising. The overall survival actually was tripled. The median survival from 29 months and versus 10 months with a significant p-value, and that was promising to proceed with this technique in this population, this patient's population. So stereotactic ablative then has been dedicated for this kind of population, elderly patients or inoperable patients. This is a trial published in 2016, showed that RTOG 0813 showed if you provide a stereotactic body radiotherapy for inoperable stage non-small cell lung cancer, you achieve local control of about 89%, an overall survival of 73%, with a grade 3 toxicity of less than 7%. This gives us the chance to push the envelope more to compare what if we can provide 5 fractions, and as the standard we usually do, or we go with a single fraction. And it showed even single fraction is promising in RTOG 0915. So in an elderly patient or in an inoperable early stage non-small cell lung cancer, we can provide a single fraction and we can achieve a decent local control and and safe treatment. So why did the evidence still controversial on this subject? The identification of the target population, standardization of patients' characteristics, and the variety of local treatment for the primary tumor, the broad variation on the dose provided in radiosurgery. There's still efforts to establish a clear and solid guidelines. Protocol commitments need to be stick with and omit bias to achieve a standard evidence as a treatment of early stage non-small cell lung cancer. This is an interesting trial in the term of trying to identify the high-risk population of early stage non-small cell lung cancer. They used the major criteria of having 50% or a DILCO of less than 50% with a minor criteria of age of more than 75. This trial was helpful in identifying the high-risk population of patients, ACOZOG Z4032. High-risk stage 1 non-small cell lung cancer, they try to compare both modality of sublobar resection with or without brachytherapy versus stereotactic body radiotherapy, RTOG 1021. This trial, unfortunately, has been terminated because of poor accrual again. So where are we now, according to evidence for early stage non-small cell lung cancer in terms of what we provide, stereotactic surgery, or to 2020 NCCN guidelines, they adopted the SPRT or SABR as an option for medically inoperable patients. So when we have a T1A, B, C N0, then SBRT is an option. Even if you go with a stage 1B, T2A N0, as just one invasion like T3 N0, T3 N1, still for medically inoperable patient, if you want to go with N0, then we will proceed with say N1 lymph node. Then we can go with the conventional type, not the SBRT, concurrently with chemotherapy. So what is the take-home message for early stage non-small cell lung cancer in terms of radiotherapy? We will try to conclude all the literature as this slide. It's very helpful, honestly. When you have a patient with a standard risk, then the superior management will be lobectomy. If you have a patient with high risk, and which will help you on identifying these patients is having, as we mentioned, a poor lung function as well as performance status, then SBRT would be a better option. In inoperable patients, we have a solid evidence that SBRT is superior to surgery. So this is an ASTRO guidelines, it's the American Society of Radiation Oncology. Once you have a standard risk patient, early stage non-small cell lung cancer, mortality is less than 1.5, SBRT is not recommended. Then we would push for surgery. Once you have a high risk patients with a mortality of more than 1.5, poor lung function, elderly patient, then SBRT would be considered as an alternative to surgery and should be endorsed. SBRT is still an option. T3N0, SBRT is an appropriate treatment option as well. If the biopsy is not feasible, there is available evidence that SBRT should be considered as an option after discussion in a multidisciplinary tumor board. Once you have a tumor size of primary more than 5 centimeters, then SBRT should be conditionally recommended. What about real cases? What we are trying to prove that the options now is being available even for non-operable patients or elderly patients. This is a 75 years old patient we had. He had the early stage non-small cell lung cancer. He was not a surgical candidate, and he was classified as a high-risk patient. So what we have done, we treated him with stereotactic ablative body radiotherapy. We used the CyberKnife technique, and even we went, given his age and the circumstances, we give him even the single fraction, which has been recently approved. We went with the 34 grain single fraction, and we treated him in a single day. We achieved, thankfully, a good local control, and the patient is still alive. So this is the upgoing and ongoing trials discussing the role of stereotactic ablative body radiotherapy in early stage non-small cell lung cancer, and hopefully we will reach on identifying a solid base evidence for treatment of these kinds of population. Thank you.
Thank you so much, Dr. Salim. Thanks for such a nice overview on the radiation, especially in the early stage. I think we have probably one question because of the timing, and my question is probably on the radiation. You know that right now, probably this is outside the early stage topic, but we start to see this quite commonly, especially in those patients with the driver mutation, those who has been responding to a treatment for a while, and then they have those sort of oligoprogression. And since we try to stick with the treatment and try to work on those side that's probably progressing, and probably you are seeing those. And my question is, what's your report on that, and regarding the number, the size? Does it impact on the way to treat when you treat them with high dose radiation for those who have been treated or have oligoprogression? Or another example is oligomets, where you have as synchronous primary or synchronous lesions that could be a primary or metastatic, and those might be inoperable to start with because they might be metastatic, but on the same way it might be another primary on the contralateral side, and surgery might be a high risk to conduct.
Excellent question. If we talk about this radiation therapy and this technique and delivering it, if we talk about non-small cell lung cancer early stage, then the outcome is promising. If you are able to select the best patient who fit for this treatment. As we mentioned over the talks, if you have a T1, T2, less than 5 centimeter, then we will push hard for SBRT, especially, as we mentioned, if the patient is high risk or as the patient is inoperable. So the size limits is still within less than 5 centimeter, and the location as well. There's ongoing trial saying if you have a peripheral location or central, you're okay. The difficulty and the challenging is when you have a central location. Definition of ultra-central is when you have a lesion touching the central structures like the bronchi or the trachea. We still have good outcome in terms of local control, and the toxicity is still ongoing to define the better dose, and we have it, fortunately. When we talk about the number of lesions, then we are either talking about stage 4 or oligometastases. My personal opinion, I don't see there is a limitation of numbers. We used to treat up to 5 lesions in each lung. So the limits is the normal reservoir of the lung. So if you've been able to deliver this radiation in a precise manner, accurate way, and try to preserve the normal tissue, we have a constraint and limits for the normal lung tolerance, then you are okay to deliver the radiation therapy.
Thank you so much, Dr. Salim, for this nice and overview and discussion, and thanks for having you at this meeting. So I think now we are, before we go closing the session, we have to go with the satellite symposium. I think we have a satellite symposium that sponsored by BMS, and for this I would like to share my slide. I will be the speaker for this event. If you just allow me to share my slide so we can go with that, and then we can so I think the slide now is on the screen. So first, so I think we do have, we will have more data about immunotherapy on advanced stage, and that will be a discussion that we will get on the second session. But today, I would like to thank BMS for organizing this satellite symposium, and the talk will be more toward or focused toward the dual immune checkpoint inhibitors new regimen that we have at this ASCO this year. The immune combination is being addressed for the last number of years, and we all of the time we're learning about that, but my talk will try to minimize to or limit the talk to the dual immuno with chemotherapy, which is the CheckMate 9LA's trial, and I will try to make a quick overview with the other combination data, though it will be addressed in details in the second session. That would be the disclaimer for my talk. When we treat patients for advanced stage non-small cell lung cancer, we are always looking at the different markers that have to do with the histology, molecular, clinical performance, and so on. And then we classify patients on either oncogen addicted or non-oncogen addicted. And this has been addressed a while ago with Dr. Saeed, that those patients with the driver mutations, the numbers is increasing, and we every time now we are getting a new one or new druggable driver mutations, and the number is increasing, and even the percentage is getting higher. But still, we have high patient proportion who have no druggable driver mutation, and the options that we have with such patient population is either immunotherapy as a single agent, or combination of immunotherapy with chemo or other immune checkpoint inhibitors. So immunotherapy combination story is one of those nice story to tell, to be frank with you, and it's things this has been started probably 5 years back with the data that we have with a single agent checkpoint inhibitor, which is mostly anti-BD or BDL1 inhibitor, and those data was started initially in the patient who has been heavily pretreated. Then we have data more on the second line compared to the control arm, which is the docetaxel, and from those trials we have learned that there are some biomarkers that's probably useful, which is the BDL1, and we try to select patients who are benefit the most from such treatment, and then those agent as a single agent has been tested in a high expressor, and it's really work and become a standard of care. However, we know that not all patients do benefit from a single agent checkpoint inhibitor, especially the BDL1 as well, and therefore a number of combination strategy has been tried. The first combination strategy was to add chemotherapy with or without bevacizumab, and then the other combination strategy is to use dual checkpoint inhibitors. We know that chemo, different checkpoint inhibitors, anti-angiogenic, specifically beva, have more kind of synergetic effect. So the chemo can add to the response. It can also induce an earlier response, which is something that we don't see with a single agent checkpoint inhibitor. The dual checkpoint inhibitors also can add to the duration of response, and that's really an important, especially with a disease that we need to control for a long period of time, and this might also translate it in a better overall survival as we move on. And that will be the topic for today. Our the new concept that it was addressed this year is the combination of all, the combination of dual checkpoint inhibitors in order to have durable response rate. On the same time, addition of chemotherapy just to have a deeper response and earlier response. And with this combination, we might have we might achieve better response and earlier, as well as probably a durable response, and this might also translate it in a better overall survival. So the story started with single agent. In the second line, we have number of agents that has been tested, and in fact, it was approved starting from nivolumab in the squamous, in the non-squamous histology, and we have seen that also those trials was addressed those trials was in fact addressing the role of single agent checkpoint inhibitors with versus chemotherapy, which is the control arm. And we also have other trials that look at the different checkpoint inhibitors. Pembrolizumab also was one of the drugs that has been tested in a patient with PD-L1 positive tumor, and also we have atezolizumab also has been tested, and all of these three drugs was in fact approved mostly in patient with advanced non-small cell carcinoma, second line, regardless of PD-L1 expression, except the pembro, which is only included in the PD-L1 positive tumors. However, what we learned from those trials is we know that one of the important biomarker, although it's not a perfect biomarker, but it's really quite useful to select those patients who benefit the most from such agent. And we know that those patients who have high PD-L1 expression of more than 50 are the ones who benefit the most from single agent checkpoint inhibitor compared to chemotherapy. However, this biomarker is not perfect. It's not something that it's not a binary biomarkers where we have yes or no, white and black. The best example for those binary is, for example, an EGFR and ALK. Either we have an EGFR that's present and those patients, they will respond, or negative where they don't respond. But when it comes to PD-L1, it's quite different. It's more kind of quantitative biomarker that range from 0 to 100. And what it can tell us, this biomarker, is either we have a likelihood of response when the tumor in this range of likelihood of not responding if it is in this. But still, we have patients who are not responding, though the PD-L1 expression is high, and we have a small proportion of patients who still respond even with the lower PD-L1 expression. However, it was quite useful to select especially those who might benefit the most with checkpoint inhibitor, and we have 2 clinical trials that really showed positive outcome with a single agent in high PD-L1 expression, and the first one was the KEYNOTE-24. Then we have another trials that look at the different checkpoint inhibitor, which is the EMPOWER 110. Those trials will be addressed in details in the next session. But I will show you one of the key slides from the first one that led to the standard of care that we have for the high PD-L1 expression, which is the KEYNOTE-24, which is look at the pembro versus platinum-based chemotherapy, and we have an updated 3-year survival that showed the benefit is there, and it's really maintained even with a longer follow-up. However, the combination strategy has been addressed, since not all patients really benefit from single-agent checkpoint inhibitors. Also, we have number of proportion of patients who might have low PD-L1 expression, negative PD-L1 expression. So I have a problem with the slide. So and that's why the combination of all the chemotherapy and Avast and different checkpoint inhibitors, all of them have more kind of synergetic effect when it's combined together. This was a more kind of theoretical rationale. However, in fact, it was confirmed of a number of clinical trials, and we will hear more about those clinical trials in the next session. However, these are the names of clinical trials. We have the first combination strategy that was tested is the checkpoint inhibitor with chemo with or without BEVA. And we have a number of clinical trials that look at this kind of combination, starting from the KEYNOTE, EMPOWER, as well as addition of BEVA and non-squamous and the EMPOWER 150. And most of those trials are positive trials. The first one, the KEYNOTE 189, which is look at the patient with who has been treated with chemo plus immuno. The immuno was a pembro and versus chemotherapy, and it really led to the approval of this regimen as a standard of care in patients with advanced non-small cell lung carcinoma, regardless of the PD-1 expression. The same concept has been applied also with EMPOWER 150, which is of chemo immuno plus BEVA in those patients. However, there are also a number of trials looking at the different combination that's chemo-free regimen, and that would be the dual checkpoint inhibitors. We know that PD-L1 or anti-PD-L1 can work in a synergetic effect with anti-CTLA-4. Anti-CTLA-4 really can induce the de novo anti-tumor T-cell response through different mechanism of action that might have to do with the memory T-cell, increase in the PD-L1 expression. At the same time, anti-PD-L1 such as nivolumab can restore the anti-tumor T-cell function, and that's through increase of cytokines, enhancing the pre-existing T-cell response. This was theoretical that was proven in number of in a clinical trial, which is the CheckMate 227, and we will go over that probably in the next session. The other trial was a negative trial. And it's also look at a different concept with a different agent. The dual checkpoint inhibitor has been tested not just cancer, lung cancer, but also it has been tested with a number of other cancers. In fact, the follow-up that we have with other cancer is much longer than what we have with lung. We have 5 years follow-up with melanoma, we have 4 years with RCCC, and it's been a standard of care in those disease sites. At this ASCO, this combination or the combination or the new combination has been tested, which is the inclusion of dual checkpoint inhibitors, including anti-PD-L1, anti-CTLA-4, with limited cycle of chemotherapy. We know that the anti-PD-L1 as well as the CTLA-4 can cause high response that are durable, but we also have an issue with earlier, those who might be progressed early. And that's why the chemotherapy has been put as one of the important intervention in order to provide more kind of rapid disease control. This might also translate it in a higher response and also durable response, and this might also have a better impact on the long-term outcome of such disease. This was the CheckMate trial that has been presented at this year at ASCO 2020, and also we have more update from ESMO, which is mostly on the quality of life or patient-reported outcome. The simple design for it was quite simple in the design. Patient who has been included are patients with metastatic advanced non-small cell lung carcinoma. No prior systemic therapy was given. EGFR and ALK was excluded, and all patients was being included, regardless of the PD-L1 expression, whether squamous or non-squamous. The control arm is the chemotherapy, which is the standard at that time, which is the chemo 4 cycle, depending on which histology. Pemetrexed was allowed for the non-squamous. And the experimental arm is Nivo at 360 milligram every 3 weeks with ipilimumab every 6 weeks with a 2 cycle of chemotherapy. The primary endpoint was an overall survival with a number of secondary endpoints, including PFS, overall response rate, and PD-L1 expression efficacy parameters. The baseline characteristic was including all patients. What's really matter is all patients with different PD-L1 expression has been included. There were almost 20% to 30% were high expressor. Squamous, non-squamous, 70 to 30%. Most of those patients are never smoker, median age around 65 of age. The duration of treatment in the experimental arm was 6 months, while it's 2 months with the chemotherapy arm. Around 50% or 45% have received pemetrexed maintenance in the control arm, and those mostly the non-squamous histology. The primary endpoint for this trial was an overall survival, and it really it was a positive result when you look at the overall survival Kaplan-Meier curve. What's really important to highlight is we start to see a separation of the curve, and this is one of the important concept or theoretical concept that has been looked for this trial, or the inclusion of chemotherapy, just to have this kind of early separation of the curve. The result, the curve was separated, and it was continued to be separated with 12-month follow-up. There was almost 5-month absolute benefit in the overall survival with a hazard ratio of 0.66, and it was a quite significant result. All patients, they did benefit with the combo, whether regards of the age, squamous, PD-L1, majority of them really did benefit, except one of those few patients that have different, for example, small proportion of patients with more than 70, and that's represent a very small proportion. So histology, regards to the histology, all patients, they did benefit, whether they are non-squamous histology or squamous histology. There was almost kind of 6 to 5 or 6 survival, whether non-squamous or squamous, and we can see at the rate of survival, even with the longer follow-up, you can see that the benefit is quite preserved. All patients, they did benefit, whether they are PD-L1 negative tumor or PD-L1 positive, lower expressor or high expressor. All of them have achieved quite clinically benefit when it comes to overall survival. BFS also one of the secondary endpoint. Numerically, it was probably 2-month difference, but when you follow those patients for 12 months, you can see that the BFS rate at 12 months is almost kind of double the one that we have seen with the control arm, and it was quite significant from a statistical point of view. The response rate was also one of the important parameter and concept with this combination, and you can see the response is higher with the chemo-immuno. It's around 30 to 40% versus 25% with chemotherapy. We start to see lower progression compared to the chemotherapy, and the duration of response, which is one of the aim of immuno. In fact, the dual immunotherapy, you can see the duration of response, it's almost double with the chemo-immuno combination. The side effect was, there's no surprise, there was more side effect on the chemo-immuno, but there was no significant treatment-related death between both arms. And most of those side effects was kind of nausea, anemia, and other side effect that's probably related to the chemotherapy part. The side effect that was related to chemotherapy, when you compare both arms, as we described with the chemo-immuno, we had patient received 2 cycles, while here they received 4 cycles. And what we can see that the side effect in the chemo-immuno or the chemotherapy side effect is less, whether anemia, whether neutropenia, since patients are received less cycle of chemotherapy, so that's was unexpected. The other side effect that's important to keep in mind is the immune side effect, and there is no surprise that we have seen there is therapy. It's higher. Most of those side effects are either skin, endocrine, gastrointestinal, hepatic, and this is something we have seen with the dual checkpoint inhibitors. But what really reassuring is most of those side effects is kind of a grade 1 to 2. Very few patients have got higher grade side effect, including 3 or 4. At ESMO, we have more update about this trial, or more kind of exploratory analysis for the quality of life or the patient-reported outcome, which is either classified either disease-related symptoms or overall health status, and they also look at the number of scales to measure those in perspective. From a disease-related symptoms, what we have seen is both arms showing a continuous improvement in the disease-related symptoms. From the start, you can see both arms really, not just the chemo-immuno showing an improvement. Really showing a better symptoms or disease-related symptoms as we move on with the treatment. The same thing also we have seen with an overall health status. From the baseline, we can see that both arms led to improvement on the overall health status, and having a chemo-immuno did not really impact. In fact, all the benefit has been preserved with a longer follow-up. As we move on to the disease progression, we can see that the time to definitive deterioration on those measures, it's become in favor of the chemo-immuno arm. And that's what's seen across different scales. So in conclusion, CheckMate 9LA trial is really data that we have with with the chemo, immuno, and other combination strategy that we are using with non-small cell lung carcinoma. It's really met the primary endpoint for an overall survival. As based on the pre-planned interim analysis, there was clinically meaningful improvement seen in the number of efficacy measures. We have a minimum of follow-up 12 months right now, and it's still and we have seen an overall survival benefit, and so longer follow-up would be required. The magnitude that we have seen with the chemo immuno was seen across different patient population, regardless of their disease characteristic, whether they are PD-L1 positive, negative, squamous, non-squamous, and there was no new safety signals that we have seen with the addition of 2-cycle compared to the safety that we have seen with the dual checkpoint inhibitors. With an earlier separation of survival curve and lower progression disease rate, that's probably indicated the hypothesis that has been designed for the CheckMate 9LA has met. With addition of limited cycle, we have seen that this is probably, we have now more options to have in the first line therapy with other combination strategy that already has been approved for the same indications. Having chemo immuno also showed an improvement on on the quality of life as we move on. With this, I would like to conclude, and I will finish my share with this. So I think we are almost at the end of our session, and I'm not sure if we have a question. So there is one question I would go with. There is which subgroup patient you would go with the dual checkpoint inhibitors. And to be frank with you, I think it's dual. It's an option. However, we need to select those patients who are for combination strategy. We have chemo, immuno, we have immuno. There are a number of factors you need to look at. You need to first look at whether chemotherapy is an important or is indicated for similar for such scenario, because with those patients we have either chemo-based regimen or non-chemo-based regimen. It's also depend on the availability of the checkpoint inhibitors that you have at your institution. Many of the institutions we don't have the ipilimumab, and I think that's one of the options. But I don't think we have a subgroup that they will be used for a dual checkpoint inhibitors. I think we have a patient population that also might be an option for the combination strategy. So that's with this, I think this session, and I would like to thank Dr. Jazia for having us in this event, and I'm sure there will be more there will be a break for a 20-minute, and we should be back by 7:40 for the second session. For 5:40 for the second session, inshallah. Thank you so much, and I would like to thank everyone speak, and I would like to thank all the audience. I would like to thank Jazia, and see you inshallah in 20 minutes from now.
Thank you, Dr. Abdullah. Thank you, everybody. We'll see you in 20 minutes, 5:40, inshallah.